Greetings. Let me share this talk on infection control in the endoscopy unit that was prepared for the internal medicine GrandRounds at the University of Texas MD Anderson Cancer Center on June 19, 2020. At the outset, I would like to thank Dr. John Stroline, Mr. Charles Butt for the grant support, Ms. Angela Deal for her medical illustrations, and Ms. Sanji Suresh for assisting me with the development of endoscopy tech training program. I would like to take this opportunity to dedicate this talk to my endoscopy staff at the University of Texas MD Anderson Cancer Center for their passion and dedication to provide excellent patient care. Here are my objectives for the talk, and let us look at the scope of the problem: hospital-acquired infections. About 1.7 million infections occur in the United States, 99,000 deaths related to those infections. And if you look into the details, medical device-related outbreaks, we use a lot of devices. Among the various medical device-related outbreaks, GI endoscopes and bronchoscopes lead the pack. And in fact, endoscopy-related infections outnumber all other reusable device-related infections. And when you look at which endoscopes are responsible for infections, as you can see here, upper endoscopes, colonoscopes, ERCP scopes, bronchoscopes. There are reports of infections related to every scope. But recently, ERCP scope gathered a lot of attention in 2015 when the CDC investigated an outbreak of infection following ERCP. And that infection was a lethal infection due to carbapenem-resistant enterobacteria, otherwise called as CRE. One should thank for the exceptional work that CDC offers in keeping us safe. Since 2015, since then, there were a lot of outbreaks, especially related to CRE and ERCP scope. More than 20 outbreaks, 250 infections, and more than 20 deaths. And this led to the FDA bringing experts in the field, CDC, industry leaders, as well as leaders that provide, that manufacture high-level disinfection units. And the panel concluded that endoscope reprocessing is responsible for the infection. It could be related to human error, and it could be related to the scope design. And in the last 5 years, a lot of research has gone to figure out ways to improve and cut down this infection. When you look at the scope of problem in terms of ERCP-related infections, currently about over 500,000 ERCPs are done in this country, and with a reprocessing defect of 2%, it will lead to about over a 10,000 patient exposure. Whether that exposure translates into real infection, we do not know. But we should do everything possible to cut down the risk of exposure. And when you look into Why do infections occur? It is pretty complicated. And my reading and my understanding goes this way. There are three basic issues. We do a scope, and the scope goes into the gut. The gut is heavily contaminated, and the scope gets contaminated with the gut bacteria. But the scope has lots of channels, complicated device that is difficult to clean. And if you don't clean it properly and on time, biofilm develops and the cycle keeps going. And once the biofilm develops, it is very easy for more bacteria from the gut to stick to the scope, and it becomes very difficult for even the best person to clean that scope. So let us look at gut to have a little bit of understanding about the heavy bacterial contamination in the gut. As you go down from the esophagus to the stomach, to the intestines, to the colon and the rectum, the microbial load keeps increasing in a logarithmic fashion. About 100 bugs may be there in the stomach. By the time you go into the small intestine, it becomes 1,000 to 100,000, and when you go into the colon, it is more than 1 million bugs per ml. So as you can see, the gut flora has a lot of bugs that can easily contaminate the scope. And why is an endoscope difficult to clean? And let's look into this. In the last 50 years, endoscopy has certainly revolutionized the management of gastrointestinal diseases and virtually replaced surgery on many fronts. And this scope, depending upon what the patient has, you may use a shorter scope or a longer scope. You may use a thinner scope or a thicker scope, or you may use a scope with a side viewing or with an ultrasound at the end to take care of different problems related to the GI pathology. So first, there are lots of different varieties of scopes. And when you look at the scope, it is a very complex machine which has multiple channels, small channels that can take air or water, that can suction fluid or air. It can take cables of light and images back. And finally, there are different wires to allow the scope to be like a noodle and twist and go around the bends of the gut. And there are lots of buttons. The buttons that control different functions of the scope. And these buttons have seals that could become leaky and cause problems. And finally, the scope has long channels that are small caliber channels which are difficult to clean, and they have angulation that can retain the bacterial film because those angulations are very difficult to clean. And finally, when you look at the ERCP scope, it has an elevator. That elevator is the one that has revolutionized the management of pancreaticobiliary diseases. This elevator would allow us to get into the bile duct or into the pancreatic duct, remove the stones, put in stents, and for the most part avoid unnecessary surgery that was required before the scope was developed. But at the same time, that elevator is very tiny and it is very difficult to clean. And that's where the bugs can stay and the bugs can infect people. So, we learned about the complexity of the endoscope, and let's talk about the biofilm development. In simplistic terms, think about you drink a mocha in your own cup. And if you decide not to clean it because you're so busy, and it will take a longer time for it to clean it. It may be very difficult to clean it because the material gets stuck to the wall of the cup. The same thing happens once the endoscope comes out. If we do not clean it immediately, then the proteinaceous material can get stuck to the channel and the bugs can grow in that proteinaceous material. As you can see here, once the biofilm develops, bacteria love that biofilm and they keep growing. So what do we do to prevent infections? In other words, what do we do to prevent the biofilm development? That's what it is about infection control in endoscopy-related infections. Let me take you through an endoscope reprocessing journey. What happens when the endoscope comes out of a patient before it goes back into the next patient? So here is an endoscopy unit. As you can see here, you know about the reception area where you check in, you get prepared, and then you are taken into an endoscopy room where a procedure is done. And after the procedure is done, the scope goes to this soiled scope cleaning area, which is like the kitchen area. And that's where most of the stuff happens to keep you safe. So once the scope comes here, it gets tested for any leakage. And following the leak test, it goes to the sink for cleaning, brushing, cleaning, etc. And then you check the scope for any damage or if the cleaning was perfect or not. If not, you go back to the same cycle. Once you're happy that the scope was clean, then you take it through the next level, that is high-level disinfection for getting rid of the microbes. And following that, you take it to the scope drying area for drying before it gets stored. So there are lots of steps that the scope takes in its journey. And let's find out what each step involves. Before you go through this process, the endoscopy reprocessing personnel is at risk for exposure to infections, and that's why they should protect themselves with a proper PPE. And now with COVID, they should also protect themselves from airborne infection with N95 masks. So let us look at the various reprocessing steps. The first step, the pre-cleaning of the endoscope, is the single most important step. It removes, as soon as the endoscope comes out of the patient, the assistant does pre-cleaning, which involves removing the debris and microorganisms inside and outside the endoscope. If you do it immediately, you will save yourself a lot of unnecessary expense down the road. If you don't do it, the biofilm develops and it's very hard to get rid of the biofilm. Infections can develop in patients, infections can develop in the reprocessing personnel, and if you don't do it, the scopes get damaged, and each scope is $50,000. The repair cost is $10,000. So when you do two procedures on a single patient, as an endoscopist, you should let your technician do the pre-cleaning and take the scope back for the next step of reprocessing. Do not let the scope sit in the room. That is one thing, simple thing that we should do. Next, after pre-cleaning, you take it to the scope cleaning area where you do the leak test to check for any holes. If you don't do it properly and there is an ongoing leak, it will contaminate the scope, it will be a source of infection and heavy bills for repair. Following that, you do the manual cleaning, which involves brushing and flushing of the scope inner channels. And when it comes to brushing, picking up the right sized brush is really critical. Every small detail in the manual cleaning process makes a big deal. You should do the manual cleaning under full immersion so that the scope gets cleaned properly. Finally, you take time to inspect for cracks, and if there are cracks, you send the scope for repair. You don't put it through the cycle and go back to the next patient. If you see retained debris, you have to go back to the manual cleaning again until you see no debris. These steps, the pre-cleaning, leak test, manual cleaning, endoscope infection, are the most critical things that need to be taken care of by every endoscopy unit. And after that, the high-level disinfection destroys the vegetative microorganisms, mycobacteria, fungi, and viruses. When it comes to here, don't take any shortcuts. It has to go through its length of cleaning. And you have to take precautions in making sure the concentration of the high-level disinfection solution is up to par according to the manufacturer's instructions for use. Following that, once the scope comes out, you should dry the scope. 10 minutes of air dry is the most important thing to get rid of any water in the channels. Any little amount of water in the channel will be a source for Pseudomonas. So it is very important to take time, not blow a little bit of air and then move to the next scope. 10 minutes. Nowadays, there are special scope drying units that will blow air continuously, and if you have that, that makes it even better. And you have to hang the scope vertically to keep the scopes dry. The goal is to have a clean scope and a dry scope once a scope goes through this journey. So, although we know all these things, why did FDA intervene? Because FDA felt that there were several problems related to scope-related infections, and they came up with these recommendations. One, there should be enhanced oversight, training, competency assurance for the frontline reprocessing staff. Next, there should be proper attention given to pre-cleaning and cleaning steps before usual automated high-level disinfection. One should follow or adhere to the manufacturer's instructions for use. And finally, a good record keeping is essential to track any scope-related infection. It's almost like tracing for a COVID case. So similar to that, unless you keep records, nothing is going to happen. So how do you know whether you have cleaned the scopes well or not? What you do is you culture the different channels and the elevator recess. And then if the culture results come negative, you should be happy. If the culture results come positive, that means you have a problem with your scope reprocessing. A large Dutch study has looked at their ERCP and EUS scopes. It's a big study, and what they've shown is 15% of the scopes are contaminated after going through this process of instructions for use cleaning. And it's not dependent upon the age of the scope or the use of the scope. So that means that those units which follow the instructions well and do it like religion, they have less contamination, but those that do not follow, they have a problem in their hands. There's another large study from the US. Again, they have shown that 18% culture positive after first high-level disinfection. And interestingly, this was following the manufacturer's recommendations for cleaning. So it raises the question that there may be issues that we need to further figure out so that we could cut down this culture positivity after high-level disinfection. So, in summary, as you can see here, once the scope comes out of the patient, it may have 10 to the power of 9 to 12 organisms, and with the pre-cleaning, there is a 10 to the power of 3 reduction, and manual cleaning, 10 to the power of 6 reduction, and high-level disinfection, anywhere between 10 to the power of 9 to 12. All right. So This is a very labor-intensive process. So people can get tired of cleaning the scopes, and if they have a problem, then the scope can get contaminated. Say, for example, if there's maximum contamination of the scope and minimal cleaning that goes on, that results in at least 1,000 to 10,000 microbes per ml remaining. So there is a low margin of safety if the protocol is not adhered to properly. So what can we do? There are several things that we can do to improve the process. One is testing for the bioburden. That is, once you do the leak test and the manual cleaning, you check for ATP. Biological material has ATP, and if you test for ATP, that means there is bioburden. It takes only 5 minutes, and if it is a pass, you go to the next step. If it is a fail, you go back and do the manual cleaning. And this ATP test is useful for training people as well as checking on experts whether they're doing it properly or not, so that you can maintain a quality standard. Others have looked at whether we should go with the quarantine, like the COVID, whether you can quarantine a scope. So this is a beautiful study from University of Pennsylvania. What they've done is they did pre-cleaning to manual cleaning within the first hour, from manual cleaning to high-level disinfection again within an hour, and then every Friday 25% of their endoscopes were sent for culture. And if they're culture negative, they remain in circulation. If they're culture positive, they took them back for more cleaning and quarantining. And they found that with this process, I feel that doing it quickly, the manual cleaning, pre-cleaning and manual cleaning all on time by expert people cuts down the amount of culture positivity. And for them, it costed about per year about $1,500 per scope per year. But you need to have a large inventory to do the quarantine process. What are the reprocessing options we could consider to overcome this problem? So you go through the high-level disinfection, the whole series, and then go back to again manual cleaning, and then again high-level disinfection. That is repeat reprocessing of the whole cycle. That is, once you do that, the scope is as clean as that you see in sterile water. Or because that is a pretty labor intensive. And there's another group that looked at instead of repeating the whole process, once they've come out of the high-level disinfection, they did a second high-level disinfection. And again, this is a randomized controlled study, and with this also they've had excellent outcomes in terms of cleaning the scopes. People have talked about sterilization, gas sterilization. Gas sterilization is going to be very challenging for endoscopes. First, there is a risk of carcinogenicity and teratogenicity. It's not readily available, and it takes a longer time for the scope to come back, and you need more scopes in the inventory. There is some talk about liquid sterilization with using paracetic acid, but we don't have much data. Another concept that people have talked about is if you know that a patient has a drug-resistant bug, and you know that patient has that scope you want to make sure that you culture and it is negative before you use that scope for any other patient. So you want to do culture quarantine for specific small set of patients. One of the things that is important is endoscope maintenance. And in this study, where they did a scope autopsy of infections related to the ERCP scope, what they found was there were 4 problems. There was some miscommunication about reprocessing, and damaged parts were not detected. That means if there is a damage, it leads to bioburden, biofilm and bioburden. And if the repair was not correct, and again, design processes. So FDA also asked the companies to come up with a design to solve this problem, and they did come up with excellent designs. So you have two options. One option is forget about the whole reprocessing. So instead of reusing the scope, you come up with a disposable ERCP scope. The Boston Scientific has come up with a disposable ERCP scope for this function. And one has to think about the cost because disposable instruments are costlier. And then one also has to think about the environment. If there are 600,000 procedures done in the US, just in the US, what will it amount to in terms of the plastic and metal waste, and how will that be taken care of? These are issues that need to be addressed as we go along. The next step is you maintain the process as it is, but you figure out a way to deal with the elevator. So the Olympus, Pentax, and other companies have come up with an ERCP cap. That means you take away the elevator cap and put a new elevator cap, and that makes it easy to clean the scope. Recently, there is a seal that has been developed to cover the elevator with a seal as another concept. So these are new concepts that are being introduced, and hopefully that will take care of the infections related to the scopes. So we have issues, and what needs to be done? FDA came up with enhanced training, oversight, competency for reprocessing staff, and AGA mentions that certification of endoscope reprocessing staff has been proposed, but so far not adopted. So let me take a step back, and I want to share with you what we have done at the Texas Medical Center in Houston. We have a group here that is called the Texas Interventional Endoscopy Group. Endoscopists from Baylor, MD Anderson, UT Houston, Methodist, St. Luke's, UTMB, Texas Children's, and also people in practice. We all get together and we do annual endoscopy nurse and tech training courses. And during the 4th annual course, we did a survey. And this survey was done by Sanjay Suresh. We took 105 attendees and we asked them 10 questions on infection control. And this is the data, but I would like to show you the summary. So 1 in 4 technicians had prior training as surgical or sterilization techs. Majority of the endoscopy techs come in and learn on the job. So that's a problem. Number 2, 1 in 2 start endoscopy disinfection process independently after a month's training. And then 1 in 3 endoscopy technicians are certified in reprocessing. Majority are not. And although their confidence level about reprocessing is 10 out of 10, their knowledge level is at 60% in terms of the correct response. So this gives us an opportunity to address a gap. And we collaborated with the Houston Community College to develop the endoscopy tech training program, and I want to share the journey. So in 2015, I wrote a letter to Chancellor Dr. Cesar Maldonado of HCC, pitching the idea about the need for endoscopy tech training program. He introduced me to the president of the Coleman College of HCC, and along with the senior nurses of the medical center, we met with him and we started working in 2015. We did a curriculum survey, DACUM survey, with 10 technicians from different parts of Houston. And we met maybe every 2 to 3 months from 2016 to 2018 to develop a curriculum that has been finalized in November and that has been approved by the Southern Association of Colleges and Schools. So that's been progress so far. And the DACUM has told us that the endoscopy technicians do a lot of different procedures, use multiple tools, require a lot of knowledge, and need to have a wide variety of skill set. So the course material consists of a prerequisite semester, and then in the first semester and second semester, they go through different aspects related to endoscopy. And we at the University of Texas MD Anderson Cancer Center, with the support of John Storline and Charles Butt Endowment, working with Angela Deal and Sanji. Angela, a medical illustrator, Sanji, an educator. We started developing the course material for the endoscopy tech training program. And we have this type of outline, and the course material would like to test the knowledge and the skill set. When it comes to knowledge, why do we do, what do we do, and skill set is how do we do whatever we need to do. And we're going to create an illustrated learning material along with post-test and demonstrating videos, followed by checklists to test competency. I had the distinct honor of inviting Dr. Steve Edmundovich, who was the president of ASGE a couple of years ago. He came to the course and participated in the course at the brand new building that was dedicated for state-of-the-art learning at the community college. And as this was going on, my good friend Roy Sitikno started exploring flipped learning for endoscopy disinfection that consists of 8 hours of learning. And we combine all these resources and hope to start the endoscopy tech training program this year, but because of COVID, we will be starting in 2021 spring. Thank you.